So Dr. Hannah Gordon is going to be presenting with us today on heart health. Before we begin, I'm just going to go through a little bit of housekeeping. If you can go to the next slide, please. The next slide's not advancing. There we are. Perfect. So everyone here is in listen-only mode. All attendees can ask questions. Please use the Q&A function down on your Zoom toolbar to do so. We are recording today as well, and if you have any questions or you would like additional information on this or other webinars, please email us at info@aanmc.org. So with that, I'm going to introduce our speaker with us today. Dr. Gordon is the president of the Naturopathic Academy of Primary Care Physicians. They focus on continuing education for naturopathic doctors who focus on primary care. She is chair of the Institute for Natural Medicine Primary Care Task Force, which focuses on improving health outcomes and integrating naturopathic doctors as PCPs into federally qualified health centers in Washington and Oregon. So she has done so much. Dr. Gordon, I will let you share a little bit of your journey and how you got here. And I'm going to make my face and my voice go away so we can focus on you. So thank you so much for coming today and for speaking.
Great. Thank you so much for having me. And hello, everyone. I wish I could see faces, but I will do my best with the Zoom. So thanks for having me. A little background for me. I started out in medicine with my career in nursing, and I was a cardiac nurse. So I worked med-surg. Did that for about a couple of years and then was kind of looking at expanding. I thought I might enjoy being more of a diagnostician and was interested in more the approach of the treatment plan. And so I started getting interested more in medical school, PA, NP, et cetera. So I ended up finding out more and more about Bastyr and naturopathic medicine. And that was just a natural, I think, transition for me. I love being a nurse. I still resonate very strongly with being a nurse. I loved being in the hospital. I loved high acuity and et cetera. But I started noticing, I really wanted my toolkit to expand as much as I love being in the hospital and with high complex patients. I really wanted to see how we could maybe improve keeping people out of the hospital when we were able to. So I started looking into that. So that's where I landed it with Bastyr. And then I did Bastyr for 4 years. I worked at a hospital during the entire time with med school, did a year of residency, and then I worked through a primary urgent care walk-in clinic in Seattle called Zoom Care, and saw, lots of patients every day. It's definitely more of a conventional model, but I love that they include naturopathic doctors as part of their primary care team, which I think is what we should be doing moving forward. We need to all be part of the team. And then most recently, I just finished my nurse practitioner degree. And the reason I got that was it's still difficult hiring of an ND in big settings. And for me, I see myself as a bridge because of my nursing background with the ND and now with my nurse practitioner. I really want to be involved in big settings and be able to contribute to medicine in that way. So that's kind of my path for that. All right, so now we're just going to introduction a little bit to the topic. So, I think I skipped a slide. Sorry, our agenda. So I resonate very strongly with doctor as teacher. I think this is one of our most important tools as a provider. So I'll go into that a little bit. Systematic approach of each case. While people are individual and unique, how we approach cases, I believe very strongly, is through a very systematic approach. And then social determinants of health and accessibility lens. I believe that naturopathic medicine and our work, the modalities we learn, how we approach cases should be affordable. They need to be doable. And so we'll talk a little bit about that as well. And then a treatment plan approach. And how do you kind of create a treatment plan for people, because everybody's so different. We'll go through a patient case. We can kind of make it applicable, and then as well as go through some treatment plans. I recognize there's probably a wide variety. I think there's students and residents, maybe prospective students. So I'm doing my best with keeping it to a broad audience, but feel free to ask questions and all of that throughout. And we can always do that at the end and kind of do a synopsis. So Okay. So introduction, I'm a big question asker, so I will just continue to ask questions and you can brainstorm those if you're thinking about what type of provider you are wanting to go back to school for or go to school for, et cetera. So how to approach cardiovascular health? Like, how do you approach that? What does that even mean? And then what makes a treatment plan effective? What are the tools people have on hand to use? Sorry, I have this poll in my way. Okay, what are the tools people have on hand to use? And then what are the tools that you as a provider can use to impact cardiovascular health in a positive way? One of the reasons I love naturopathic medicine is we have got an expansive toolkit. All right, so my first, we'll just leap into this a little bit, is doctor as teacher. You know, I think if people are brought into their healthcare, brought into the conversation versus a very being told what to do, or all these kind of strong language that I think in medicine we use sometimes, that it scares people, you know, and I think all of us in medicine need to practice how we deliver information, how we educate, how we go about including patients in that conversation. So I would just encourage you, motivational interviewing, counseling are really, really important tools as you go through your time as a student, maybe a prospective student, teacher, resident, and afterwards. And then the systematic approach, these are just kind of my bullet points for this of be diligent. You know, when you're approaching a case, if you're going too many ways, a lot of times we can lose the thread. Stay organized throughout the charting process. Keep it focused, keep it doable. Really go through prognosis with patients. Like, what is a sprain strain and what do I expect versus maybe a diagnosis of liver cirrhosis, right? What do we expect? What are we thinking are not going to happen next? So really kind of keeping that very systematic. Social determinants of health. Again, accessibility is such an important issue, you know, like if we are making suggestions as a provider of any type, we have to make sure people can do it, right? Or do they have the funds? Do they have the means? Do they have the transportation? Do they have the grocery store nearby? Do they have an accessible garden? Do they have a home? If they don't have a home, what are the resources that they have? Do they have a community center? So just asking ourselves that when we're taking a case or working with a patient and just being like, okay, what can we do with what you have, and being very focused on that. I think this also includes the financial impact, whether it's a medication, a supplement, we're asking to buy something for a functional approach, just being very mindful and cognizant of finances. And then last, maybe a little bit of an interesting question, is a treatment plan approach. So is a plan worthless? Could a treatment plan be worthless? And I ask this not to be a negative Nancy. I pardon any Nancys, please don't take that in the negative way. But I'm not saying this to be negative, but it's to impart that if we create this unbelievable treatment plan and the patient can't do it based on a variety of reasons, maybe it's the list is too long, maybe they can't afford it, maybe the transportation is such they can't see you all the time, then I would offer our treatment plans are worthless. So I would just be very careful as you go through school, residency, even providers, we need to be very cognizant and careful with how we develop a treatment plan so that it's actually doable. So just checking in, the term I think we use a lot in medicine right now is shared decision making. And I think that is so critical with our treatment plans, that we're actually asking patients, hey, could you do this? If not, why not? And like, let's like brainstorm together. All right, and then therapeutic order. So if you're new to naturopathic medicine, this might be some new terminology. If not, then you're kind of already familiar. But we kind of look at things from low force to high force per se, or what are those like foundations, which would be like diet, sleep, exercise, maybe love, housing. Like what are those basic things that we need for human functioning? So I'm just going to go through and kind of expand on these just a little bit. So the therapeutic order, kind of lowest, like the base. And if you look up or Google image of this, it's set up in a triangle. And so you can kind of check that out. But for the first layer, establish foundations of optimal health. And this really is just the determinants of health, whether that's, and I've already repeated that. And then number 2, we'll go into stimulate self-healing. So I kind of think of this as, you know, let the body do its thing. Our bodies are created to take care of themselves. The cells are unbelievably powerful to make us do what we can do. Now, that does not equate to some people do not get certain cells that work very well. So we're like figuring out how that fits in with that, right? But in general, the stimulating the self-healing, we can help support that. And so like, how do we help the body do that? For number 3, support and restore weakened systems. So this kind of keeps expanding to me into social considerations, environmental, food access, we can't keep it hedged into whether we prescribe something or do imaging on something. It's like, what else can we do to help support them in total? And then number 4, so address physical alignment. So this is kind of the functional piece. So a lot of times I think of this as more the musculoskeletal or spine approach, and it's restoring like structural integrity to the body. Number 5 would be natural symptom relief. So a lot of things in here we would put maybe in the botanical herbs, or maybe certain supplements, or amino acids, etc. So like, what might we pick from that list that would be supportive? And then the synthetic symptom relief, we include like pharmaceuticals within that, and when we need to launch those. And then the number 7 would be high force intervention. So this would include like surgeries, maybe we need to take out something. Sometimes we'll use the terminology suppress pathology. I do want to be careful with that term. A lot of times suppression of pathology can be twisted to mean, oh my gosh, we're like making the body not do the thing. Well, sometimes we do need to make the body not do its thing. And we need to take out or remove that cancer. So I would encourage us to look at high force interventions to be launched when needed. All right, I see in the chat box. Oh, great. Thanks, Joanne. All right, so let's jump into a case. I love cases. I think they make stories more meaningful. So this is a recent case of mine, and this is a 58-year-old male who presents for a blood pressure refill for a medication of an unknown med. He has just moved to the US. He's a new immigrant, and he's out of his blood pressure medication. We tried to look it up. We couldn't figure out what blood pressure medicine it would kind of equivalent to here in the US. A little bit more details, smokes 1 pack a day of cigarettes, alcohol use is 4 ounces of liquor a day. And then in office, his blood pressure was 130/80. So does anyone know, is this high blood pressure? Does he have hypertension based on 130/80? You can put it in the chat box if you want. If not, you can just think about it. And then what are your next steps? And the other caveat with this patient is they are cash paying. So we will consider finances as well. All right, so my treatment for him for that day, I actually sent him home with a blood pressure log and to check it 3 times a week. We did labs. So this is a point of care test. So you can just do it in office, an A1C. His blood sugar was actually 6.7 for an A1C. And then labs sent out, I sent out another A1C for confirmation because the point of care testing sometimes can be a little off. Lipid panel, a metabolic panel, a blood count, and then a TSH, which checked for thyroid. And I did not restart a medication because his blood pressure was doing really well, 130/80, without a diagnosis of diabetes. That is within normal limits. With a diagnosis of diabetes, it would include, like, we can start a blood pressure medicine. But I decided to hold. This is the only time we've seen him. We've only have 1 measurement. And so I wanted to get a little bit more record before we kind of moved forward with that. So for the second visit, he brought in his log, and his average was more 145/90. So it had averaged out to the point where, we probably need to launch some sort of treatment plan. He's asymptomatic. He feels great. There's no chest pain. There's no double vision. He doesn't have any headaches. This blood pressure would not cause any of those symptoms, but it's always good to ask. As far as his labs, his blood sugar was 6.6. So it is elevated. His total cholesterol, 233, triglycerides, 550, LDL, 130, and then HDL, 39. So this is just confirming that he does have a diagnosis of diabetes. Diabetes is a A1C of 6.5, confirmed hypertension. So with the 145/90s, hypertension on both accounts, systolic and diastolic. and he has diabetes, so it's kind of even more confirmed. And then he also has confirmed hyperlipidemia and hypertriglyceridemia. Please note these triglycerides of 550 are very high. If we get over 600, we have a little bit more of increased risk for pancreatitis. If it's greater than 1,000, then it's very high risk for pancreatitis. So just a little clinical pearl there. When you see a triglyceride this high, you want to repeat it. Any lab, another clinical pearl, whenever I talk to students and residents, is like, if you're not sure the lab makes sense, repeat it, and so we can kind of see if it was actually a lab error or a blood draw problem, or if it's actually true. Get a fasting blood, depending on what lab it is that you're repeating, and just make sure it's actually true versus just going off of one. And if you have high critical values that are abnormal, again, you want to repeat those as soon as possible. For an example of that would be like an elevated potassium or so. All right, so our second visit, treatment plan. So I ended up initiating losartan. This is a very common blood pressure medicine. I chose not to do lisinopril because lisinopril actually interacts with metformin. It's a grade C according to UpToDate. And I was kind of anticipating, depending on what his thoughts were and choices and behavioral modifications, if we needed to start metformin, then I didn't want to stop lisinopril and change more things than necessary. So I chose to start a losartan. And this is covered. We actually have a system where he would not be paying for this medication. And if he's paying if he's paying at all, it's very little through the organization that I work at. So he can afford, and losartan is a great choice for him. I also referred him to our nutritional department, which also will see him without having to pay additional finances. So I referred for diabetes and elevated cholesterol. So he will meet with them. And then I held on starting metformin. I talked with him, I talked with his daughter, that we were kind of talking about, okay, we could start lots of different meds today. We can educate, we can talk about if you want to do any behavior modifications, et cetera. And so we kind of just landed on, let's control the blood pressure, and then let's keep educating and discussing potential additional behavior modifications. So we discussed his alcohol consumption of 4 ounces of liquor per day, and just how much that impacts. So in general, lower alcohol, that alcohol is, more than the recommended per day for a male or anatomical male at birth. And so you really want to discuss like, hey, how long have you been drinking that amount? Like, do you want to decrease? Do you not want to decrease? Really assess the motivation of change for patients. Try not to involve like shame or wagging of the finger or anything like that. It's more just like, okay, you've been doing this for a long time. How do you feel about it? And ask more questions about and try to understand the reason for the alcohol consumption and see if they want to back down a little bit off of it. We discussed smoking cessation. He's at a half a pack a day. And, it was really interesting. Like when we would talk, and at future visits, we would talk, he was really excited to kind of figure out some goals for himself to start decreasing some of this. And so it was really wonderful to work with him and his daughter around like ways to decrease this. And then we also discussed his ASCVD risk, and it's high, it's 32%. So this is his risk for having a heart attack or having a stroke. And so again, we kind of like wrap this whole conversation in together around the importance of, those that baseline, right? The bottom of that triangle, kind of foundations of health, which would be smoking cessation or decrease, and alcohol consumption, and how important those two things are going to be the two most important things to decrease or eliminate for his overall health with managing his blood pressure. It's going to bring cholesterol, diabetes, all of that's going to improve if those two things are reduced. So we had a really good conversation with that and sent him home with lots of things to kind of think about, et cetera, while we got his blood pressure back down. All right. So I had him to come back for a third visit, and then there was a no-show. He didn't show up. I was devastated. I was like, oh, we're having such good conversation. So this happens, people either can't get the bus, they run out of gas, something comes up, they get sick, sometimes they don't show up. Call your patient, see what's going on, see if we need to reschedule, et cetera. So sometimes people just can't make it and life happens. And I'm sure that has happened to you as a patient as well. And you have appointments and you just can't make them. So we kind of, I'm going to park it there and take a little bit of a breath from the case. and jump into some treatment plan options for hypertension. So I love to have all of the ideas out and ready to go. And so we're just going to kind of go through those as well. So for treatment plan options for high blood pressure, the diet. So, right, we're going to start with kind of that low force intervention idea. So like, what is the base? So we'll start with diet. So DASH diet is what has the most evidence for lowering blood pressure. DASH is really important because it encourages more vegetable eating, which is amazing. And the reason, part of that though, is why is we want to have lower sodium overall in the diet and higher potassium. And like vegetables are kind of the way to do that. So it really is promoting more vegetable eating, low fat dairy products, and then decreasing the consumption of total fat, saturated fat, cholesterol, and then of course the sodium. So it's not really a salt. When you talk about it with patients, you don't want to talk about it really as a salt restriction. It's more of a salt modification. Those people who do need salt restrictions there are totally patients that you have to talk about it in that way and really be very careful to the milligram amount. But in these cases, just the DASH diet is more just in general, let's try to lower sodium and increase potassium. And if you do have a higher potassium, whether it's eating or maybe even in your blood, like that actually helps control the blood pressure as well, which is why the DASH diet is promoted for hypertension. All right, so next on the list is exercise and lifestyle. So aerobic exercise, so 3 to 4 times per week, 40 minutes, moderate intensity. This decreases the systolic by 4 to 6 millimeters of mercury and diastolic by 3 millimeters of mercury. And this is all in up to date. So please know this is just kind of backed by our grouped evidence, and it's kind of through up to date. So encouraging exercise in that way. I always want to know about sleep. If people are not sleeping, everything is just going to be harder. So I always ask about sleep apnea. And oops, I put this in the wrong, smoking got moved around. Sorry about that. So if people do have sleep apnea, you really want to send them to a sleep specialist. You want to work them up and see if they need a CPAP or go to the dentist and get like a mouth insert, etc. Because if you do have sleep apnea, your blood pressure, you're high risk for having hypertension. And then next on the list is smoking. So smoking can raise blood pressure and accelerate atherothrombotic processes. And after each cigarette smoked, there's a transient increase in blood pressure. So if you think about if you smoke every day and you're having these bumps of increase in blood pressure, then that's keeping your blood pressure higher than it would be, without, for instance. So just know that there's a difference with smoking cigarettes from an acute and a chronic standpoint with high blood pressure. And I actually learned a little bit more when I was preparing for this presentation is that there's just kind of debate. So sometimes people who smoked for a long time might still have low blood, like normal blood pressure, but they still have transient increases after they smoke each cigarette. Okay, and then for alcohol, another thing you can check in around lifestyle would be alcohol. So AFAB, if it's greater than 2 drinks per day, and greater than 3 for AMAB, then you might have an increased incidence of high blood pressure as well. So just another way to educate patients around alcohol impacts for hypertension. All right, so now we can get into supplements and botanical medicine or herbs. So I'm just going to go through a couple of these. So first up is hibiscus. I don't know if anybody has ever tried hibiscus. It's delicious, but also very tart. So sometimes you need to work with patients on how they might want to drink it. So do they like it cold? Do they like it hot? Do you want to add a little bit of stevia, or do you want to mix it half and half with another tea? Some teas do some really great combos of like crataegus and hibiscus. And so that's pretty cool to do that combo. So anyways, the first step is hibiscus, 1 cup oral, up to 3 times a day. This actually lowers systolic blood pressure by 5 to 8 millimeters of mercury and diastolic by 4 millimeters of mercury. And this is for mild hypertension cases. And there's moderate evidence for this. So hibiscus is a really good option if people like tea or if they want to keep it hot or iced, etc. And then next up is Crataegus, or also known as hawthorn. And a lot of times this comes in a standard extract, which means it's like a very condensed version of the herb, and it's a liquid. And this would be 1/8 of a teaspoon, and you could do that twice a day. And then you can increase to 1/4 of a teaspoon, also twice a day. What's interesting is evidence is a little conflicting here, and some of this is around drug-herb interactions. So again, I love natural medicines database. I don't know if y'all have ever, if you've looked into that or been exposed to that, I would highly encourage checking that out. But they really do a wonderful job of showing all of the evidence for what works, what doesn't work, what we're not sure about. Up to date, Hippocrates, some of the different more conventional models have some, but they don't have a ton of evidence or tons of information around the evidence for herbs. So I would highly encourage the natural medicines just to kind of check that out. So you want to be careful here, especially with anticoagulants, antiplatelets, anti-diabetes drugs, cytochrome P450, lithium, potassium sparing diuretics, quinolone antibiotics, that could be like your Cipro. So hawthorn would be another option. And then dandelion leaf. So dandelion is 150 milligrams up to 3 times a day. And this is interesting because there's not a ton of evidence for hypertension. However, there's the concept. So here's a clinical pearl. So when you have high blood pressure, you can have your systolic high or your diastolic high or both. And depending on what those levels are, you can be diagnosed still with hypertension. So when we think of that lower number, the diastolic is representative of your resting heart pressure, right? So when your heart's pumping, like, psh, that's your systolic. When it's at rest and filling up with more blood, that's your diastolic. So when you have a high pressure for your diastolic, we think of, oh, there might be a big backflow, right? Or there might be too much blood volume. So a lot of times that's when our recommendations, when we see high diastolic, is reduction of sodium. So if you have less sodium, people are going to hopefully pee more out and there'll be less blood volume, therefore a lower diastolic blood pressure. So the same goes for like a diuretic. So the same concept with diuretic, when we'll add, sometimes we'll add medications to lower the diastolic, and that'd be in the form of like a diuretic. And the same thing, there's herbs that are diuretic. And so dandelion leaf could be one of those. Again, evidence is not awesome for this, but the concept I think still stands, where if somebody either does not want to take a medication or you're having trouble getting that diastolic down, or you want to add a little bit of something to reduce that because their systolic is doing okay, then something like a dandelion leaf, or if you need to do a medication, you could do that with a diuretic as well. But that is your diastolic diuretic clinical pearl. If you want to reduce your diastolic, you do a diuretic, which gets more blood volume off, which decreases the amount of backflow that's happening on the heart and can reduce that resting pressure. So I hope that makes sense. If you have questions, let me know. All right, let me just jump into this Q&A. Can I repeat the database? Yeah, it's it's Natural Medicines database. Yeah. All right. Oops. Let's see. Oh no, this is going forward. Sorry, just 1 second. Okay, so next up is magnesium. So 360 to 400 milligrams per day. Again, highly encourage just magnesium-rich foods. That includes whole grains, beans, nuts, green leafy vegetables. Magnesium you can find in all of these. You can also supplement with it. So if you would like to supplement, you can actually measure magnesium in the blood as well. I think this is not really needed most of the time, but I do think a lot of times magnesium is one of the biggest depleted in our soils. So if you've got somebody with constipation and maybe a little hypertension and maybe they got a little asthma, magnesium can do a really interesting combo and really be helpful for that person, maybe in one swoop. For CoQ10, so 100 to 200 milligrams every day. So this can reduce the systolic by 17 millimeters of mercury and diastolic by 10. which is pretty significant. And the data is moderate. So this is a pretty, to me, well, I can say it's moderate data, but that can be another consideration to add for those with high blood pressure. Rauwolfia. So this is an herb. It's a powerful herb. It works. All I would say is I would really monitor heart rate. You cannot give it in someone with a heart block because it actually can kind of almost have like a beta blocker kind of action. So you definitely don't want to use it. And then I just get really cautious and careful more in the geriatric population if people are on Rauwolfia. I've seen it work. It's very powerful medicine, but I would just be very careful. So any arrhythmia, heart block, any of that stuff, please, I would hold off on that. And then monitor their heart rate. If it's less than 60, then this medicine should either not be used or decreased or discontinued. The evidence on this is low quality with decreases in both the systolic and diastolic. But again, when we talk about research and evidence with herbs and botanical medicine and all kinds of things, supplements, the data can be a little bit all over the place just because the funding, we just sometimes don't, there's just not as much funding. The other thing to consider with Rauwolfia are drug-herb interactions. And again, you're looking at your anticoagulants and antiplatelets, cytochrome P450, CNS depressants, ephedrine, digoxin. So you just want to be careful with this. If people are on, polypharmacy, so lots of medications, they've got pretty significant cardiac history, like this would not be the one I would reach for. Maybe you want to go for magnesium. Maybe you want to do hibiscus, and then we won't have to deal with like the drug-herb interactions. All right, so that was kind of the nuts and bolts of hypertension. I am not going into pharmaceutical options for hypertension. I already showed you where I was doing with losartan. So I'm trying to focus because we're doing more naturopathic modalities and how we look at it. So just know that naturopathic doctors are primary care. We are trained in pharmaceuticals. We can launch pharmaceuticals. You will learn about them in school. They are one of our toolkit, but I'm just not going into as much detail. You would consider ACE inhibitors. You'd consider ARBs. You can consider diuretics. Those are kind of your top three that you would consider initially in a case like this. And this guy I put on losartan, which is an ARB. All right, so we're going to jump into hypercholesterolemia. So again, we're kind of starting down at the base. So think of that triangle of, okay, what can we do with diet, lifestyle, exercise, et cetera, sleep? So we'll look at nutrition. So fiber greater than 30 grams per day can help lower cholesterol. The Mediterranean diet, the DASH diet. So again, for this guy, if we've got high cholesterol, high blood pressure, maybe the DASH diet is kind of the best combo for him. Mediterranean diet's great, but there's not as much evidence for the high blood pressure. There is some, but think of overlap, right? So how can we make recommendations that will target two or multiple areas? Vegetarian or other meat-restricted diets, low-carb diet, avoidance of trans fats. And then consider modifications depending on access. So again, this is kind of our social determinants of health lens again. And like, what do people have access to? If they can't make all of these changes or the DASH diet seems too big, like let's go into their diet, do a 24 diet recall or a couple of days and see like where we could maybe swap a few things that are also going to be financially savvy for that individual. So here's some examples, like replace refined grain products with higher fiber whole grain products and talk to them about like what that looks like. You can consider drinking tea, carbonated water, plain water instead of sugar sweetened soft drinks and fruit juices. So again, just more and more education. A lot of the liquids and sugar, just decreasing those is going to make everyone have less blood sugar problems, less cholesterol problems, etc. So again, going into a detailed diet recall. You can consider using nut butters instead of traditional dairy butters would be another way to just pick a few things. So we don't want to overwhelm patients. We can educate, but let's not overwhelm and find some of those things that can be easy exchanges for that individual. All right, so for supplements and botanical medicine, so red yeast rice, you'll hear a lot about this. It's kind of one of the most common ones that you'll hear about. 1,200 milligrams to 1,800 milligrams per day in divided doses. And again, in the botanical medicine field and supplement field. So those are the doses for that. Red yeast rice, again, we have to be careful with regulation just because of supplement products. You just want to make sure you're checking where it's coming in from, if it's got the appropriate stamps on it, et cetera, if FDA. And so red yeast rice actually is one of those ones we have to be a little bit extra careful with for products. And again, pharmaceuticals can get tainted with all kinds of things, and so can supplements. So just, be mindful of that and where people are getting their products and making sure we're recommending high quality products as well. And if we hear about any recalls, wanting to let our patients know. Another one, and this is one of my most favorite, is berberine. So berberine, 500 milligrams, 2 to 3 times a day. There is excellent evidence for this. I have it under the cholesterol, but this is my combo. It also reduces A1C. So one thing you have to be careful with berberine, and we'll talk about that a little bit more, is it inhibits cytochrome P450, and you do want to watch for some drug-herb interactions. But berberine can be such an excellent combo of reducing cholesterol and reducing A1C with one ingredient. It's got really great evidence. And then you can look at omega-3 fatty acids for high cholesterol. So it can reduce triglycerides, but you have to be careful because it could raise other parts within the cholesterol panel. So you just want to be careful of what those numbers are, but the omega-3 recommendations are specifically for high triglycerides. And for our patient that we're looking at today, for him, his triglycerides are probably most related to his alcohol consumption, but I don't know that for a fact. But alcohol and at higher consumption does increase those triglycerides. So for me, with him, with triglycerides, his biggest thing is a reduction of alcohol, and then we kind of will be monitoring and remeasuring that. All right, and then I'm just going to put in like another comment. Again, naturopathic doctors, we can prescribe pharmaceuticals as well. It depends on the state you're in. So if you are a prospective student, just know that all the states have different rules. And this isn't much different from any other provider type. We all have different legislation, different politics, things are different, but scope can be variable between the states. So you just want to know what your scope is. But these are just examples. So pharmaceuticals, there's multiple medications for lowering cholesterol, but statins are kind of the one you would hear most about. So I just put up a couple of examples you can look at. Most of these raise the HDL by 5%. We actually want HDL to go up. HDL helps clean up the LDL and actually bring it lower. And so you actually want to improve HDL. The other big thing that you can do to encourage patients to increase their own HDL is by exercise and higher intensity exercise. So that's a really great addition as well for cholesterol. And then the statins also lower LDL and VLDL between 30 to 60-ish%. And it kind of depends on the statin that you're giving. And then some of those also lower triglycerides. And then if you're looking at prescribing a statin, just like would encourage, there's some considerations around statin medications. So rosuvastatin, which is one of the strongest statins, has a 25% increased risk of diabetes. So think of dysglycemia. So if we're giving, it's a kind of a catch-22, and you could probably go and read up about it for days and days and days around statins, is people have diabetes and high cholesterol, you put them on a statin to protect, because it's good, because it's compound effect, and we want their ASCVD risk lower. We don't want to have a heart attack while they have diabetes and high blood pressure and high cholesterol, right? So there's a lot of decision-making made more globally with certain recommendations. But you see here, there's also an increased risk of developing diabetes with certain statins. So just be aware of kind of that dysglycemic effects when you do start statins for people. Number 2, so the simvastatin has a 15 to 20% increased risk of diabetes, and atorvastatin about a 15 increased risk for diabetes. So just something to consider depending on what your patient looks like. And then just a little clinical pearl is lipophilic statins appear to have worse adverse reaction than hydrophilic statins. And that's more just like patient tolerance of it. And one statin, if someone fails, you can try another one kind of thing. But just as a pearl around that, the comparison between lipophilic or fat focused versus hydro or water focused, as far as like the biochemistry of it. All right. And then treatment plan options. So again, like I like simplicity. I do not want to increase costs. I do not want to increase pill burden. What is a simple thing? So for this patient, maybe we could consider even some overlap of herbs or so. So here's a clinical pearl. Just think combos. Like what can we do? So what have we learned and looked at today that we might want to combo for this patient? So maybe berberine, it decreases cholesterol, decreases blood sugar. We could think about just simplifying. Increased magnesium intake, we could do that with food, so associated with decreased metabolic syndrome and diabetes mellitus, and there's a meta-analysis around that. All right, so that was a lot of information. Thanks for bearing with me. So that's kind of just like tons of options, right? And again, I just want to reiterate, you learn about all of this in school, and sometimes it's like so many details and you're like, oh my gosh, I can't wait to use it, or oh my gosh, how do I use it and how do I pick? Just know, yes, it's called practice. You'll see patients. Different things work for different people. We want to, use our foundations of health, our standards of care. That's like a really good base. And then the art of medicine is after we kind of know what our focus is, right? And then you get to talk to the patient and say like, okay, what do we want to tackle first, right? And your job as a provider too is just really to make sure to look after safety for individuals, right? So some people might not understand how important it is to lower blood pressure, but your job is to kind of like educate and see what we can do with what they've got. All right, so this is just kind of a scenario to get you thinking about what you might do in this case. So for the fourth visit, the patient returns and they do not want to start more medications and would like to trial a natural approach for his diabetes and cholesterol. So he feels great about taking the blood pressure medicine, but he is really interested in other ideas. So I've sent him to nutrition, right? But what else could we give him? So feel free to put in the chat, feel free to, write it down for your own list for what we went through, but think about what you might want to do for him. And then I will click and show you what I thought might be some good ideas. So for him, I would do berberine. I feel like this is going to be one of the best things for him to do. We have plenty of wiggle room. We'll start at 500 milligrams. We can go up to 3 times a day. Sometimes berberine, as far as a side effect, you can have a little bit of GI upset a little bit, but that's, again, you can titrate, so you start lower and move up. So this to me would be a wonderful addition, is do berberine for this patient. And then magnesium would be another one if we needed to add something in addition to his blood pressure. And so that could be a good combo. But to me, if I had to pick one thing, I would start with him. And if we were going to start something for him to like swallow versus him doing more nutrition or more exercise or behavior modifications, berberine would be one of the ones. And again, every visit I'll talk to him about like, okay, how are we doing? How are you meeting your goals with reduction of smoking, reduction of alcohol, etc. All right. So that's kind of the end of the bulk of the case and the information. And so my next task I have been asked is to kind of like wrap in what I love about naturopathic medicine. And what I can tell you, because I have done so many different degrees, and as far as that, I can just tell you, I love what we learn in naturopathic medical school. We have so many toolkits. We have a year of counseling. We have so many classes around herbs. We have things around supplements. We have things around biofeedback. We have so many skill sets that we can learn, extra certifications that you can do, visceral, manip, cranial. There's all kinds of just tools. I am somebody who loves tools. I also love to, I call myself, I specialize in generalizing. I actually love being a primary care. I don't really want to be a specialist, but I love sending my patients to specialists to do the extra things, but I love getting people started. I like being that hub. And so I think naturopathic doctors are primed for a primary care position, because we can start a lot of things. We can educate. Our education is so unbelievably amazing for health promotion. We talk about prevention, we talk about promotion in our medical system, but prevention is really screening questions, and we do such a great job of that. But There's very little curriculum in the broad scope of medicine that really actually talks about health promotion. How do you dialogue with patients? How do you figure out their motivation of change? How do you figure out motivational interviewing? What are your counseling skills? What can we offer them? How do we educate around diet, nutrition, things they can add, how they move their body, sleep, etc. And I would offer that naturopathic medical school curriculum is where we excel, is health promotion. So I just get very excited about that. Also whole body medicine approach. So just kind of taking in the whole person. What I also love right now in medicine in general, I think we are globally coming back to the importance of looking at the person together. The mind is connected to the body is connected to the shoulder's connected, everything is connected. I do see medicine kind of trending back that way, and that makes me feel good overall. But I do think that NDs have an extra power tool to really look at people from that whole body approach. And other providers do as well. So please, I work alongside my medical colleagues. I love working with my NDs, DOs, NPs, PAs, nurses, everybody, and we are all need to be part of the team. So I just want to re-emphasize, we are part of the team. There's no us against them. We are part of the team. So whether you're looking at school, already in school, done graduating, you can take my opinion for a big salt or what it's worth, but I do see us as very much part of the team. And I think it goes into team-based care. I think we are well suited to round out where medicine, I would offer, needs some improvements, and that is health promotion, which NDs are ready to go for. Health promotion focus, and then therapeutic order evaluation. I really resonate with kind of starting with those bricks. And again, we still need to include the social determinants of health within that because everybody's scenarios are different. So we need to be creative and work with patients with that. All right, so looking forward, so just a little bit more about me. So I am newly hired back in the fall, but I am the site medical director of ICHS. So it's the International Community Health Services International District Clinic. I've been hired to do a primary care. So I'm the medical director, and then I also do primary care. And they also want me to kind of either bring in an integrative medicine department, clinic, program, et cetera. So we'll be looking at programs that already exist and function well in the US, see if they work well with the ICHS team, and then I'll be director in running that. And then hopefully within that, depending on what we find, or if we need to adjust a template, we'll also create shareable templates for other community health centers and federally qualified health centers. So we don't keep recreating the wheel, right? We want to see what works and kind of expand that nationally. And then for NAPCP, so I'm president right now and executive director, and if you're interested, we need more people. We're going to have elections actually in the next little bit. So if you are an ND student and you'd be interested and you want to do primary care, if you're a resident or if you're a doc, we're going to start doing elections pretty soon. So feel free to email me about that. But NAPCP is really the kind of specialty organization for primary care, and we focus on continuing education. So we're just trying to increase our quality that we offer to NDs nationally. And then we're also doing that through NANCIAC. NANCIAC is the accrediting body nationally, and kind of push our profession towards one accrediting body for CE, which professionally I think is where we're at now. And then really to support newly licensed states on their primary care skills. So if you've gone from unlicensed or licensed but with minimal prescriptive rights and that kind of stuff, and you can't do primary care, some people need more of the skills to get trained. So we're kind of looking at expanding into that. And then as far as opinions, I've got plenty of them. So as far as advice for prospective students, I would just encourage you, go work with all of the provider types that you can get your hands on. Go find a specialty ND, go find a primary care ND. You know, like check out the differences with that. Please evaluate all programs for prospective students. Please evaluate. Do you want to do surgery? Naturopathic medicine is not for you. Please go be an MD and do amazing work as a surgeon. That is not where you need to be. As a DO, as an ND, a nurse practitioner, a PA, like look at all those programs, see where you live, where do you want to live, really evaluate. I feel very strongly that each of us has a place in medicine, and we need to figure out where we can thrive. And you can learn through any of those degree types. Of course, I have a favorite, which is my ND degree, but we all have different scenarios. And so there's a lot of curriculums you can choose. So I would encourage you to get your feet wet in all of those and go listen in on classes, et cetera, or work with them. And then another question I would encourage prospective students to ask themselves, do you want to be an employer or an employee? I think that's just really good to think future-wise about that. And then another question I was asked to answer was advantages of choosing a specialty area. So I think this is very dependent on state licensure and interest. So if you're in a state that you cannot do primary care, then I think specialty where people can actually find you and you're working for yourself in your own business, picking a specialty area, I think is brilliant. I think is a very good idea. If you're in a state that does tons of primary care and prescriptive rights and broad scope, and you want to work in a big setting, then maybe you want to be an employee and maybe you want to be more primary care focused with like an interest in a few things, right? So I work with a lot of primary care providers of various types that are primary care, but they also have interests. So they have like 25% of their patients where they're like, oh yeah, I'm going to focus on this. So that could be something that you'd be interested in. And then I put forward, I think NDs are primed so well for primary care because of our health promotion curriculum. So I want to put in a plug for primary care, but I do think that specialty, especially because we have information that I don't think is as widespread, that if you're picking a specialty, that it is wise to be able to advertise that so that people can find you when they're Googling like, I want help with this, and then they can find you because you are a specialist. So highly encourage that if that resonates with you. And then here's my contact info. So it's a little bit varied, but if you're interested in the Naturopathic Academy of Primary Care Physicians, there's our main email, and you can find us on Facebook and Instagram, and there's a website, and we're having a practicum come up, so feel free to check that out. For the INM Primary Care Task Force, there's that email. And then here's my personal email. So if you have questions for me, if you have follow-up stuff, feel free to email that as well. And then there's our websites. And yeah, I think that's about it. So I think I can hand it back over to Dr. Yanitz.
Thank you so much. So we do have other events just like this every month. And next month in March, we'll be having all the admissions counselors from the ND schools available to help you understand the differences between one school and another. In April, we'll be discussing ADHD with Dr. Korn, and we've got more events coming up the pike as well, so stay tuned. So with that, just a couple of questions coming in. One is a bit controversial, and I'm curious your take on this. I know that, we're always following the data, and data is ever changing. One day coffee is great for you, the next day it is not. And so on that vein, the recommendations around alcohol are, in some cases with the Mediterranean diet, there's a bit of red wine included. Can you speak a bit about, especially as it relates to metabolic health and alcohol? And I know that in the patient case you presented, you discussed alcohol cessation.
Yeah, I think unfortunately a lot of those answers are, it depends. So I think I am an everything in moderation person. So I'll say that versus there is a lot of data, and there's conflicting data, and everyone has lots of different opinions about it. So I think it depends on the person. I am always super interested though in the reason behind why people choose a certain habit: drugs, alcohol, cigarettes, running too much. I don't really care. Whatever the thing is, I see that as a coping skill. Or maybe they just enjoy the thing: running, alcohol, cigarettes. Maybe they just enjoy it. But I feel like one of my first questions for patients or people in general is like, oh my gosh, tell me more about that. Why do you smoke? Is it just a habit? Did you just grow up because you're around everyone else that smokes or drinks or whatever? So I think to me, that's even more important of a question than thinking like, oh, they should or shouldn't drink or et cetera. So there are guidelines, right? You don't, like women, it's kind of recommended 1 drink a day as max, right? Like that's like safe and okay. There's so much conflicting evidence if you're pregnant. Like other countries, you drink wine every day and then, you're pregnant, and it doesn't matter. So there's various options for that. And then men for 2. So in general, and those alcohol things that I brought up, it was more greater than 2 for women and greater than 3 for men per day drinks is what is giving you at risk for hypertension. So I think the alcohol question is complicated. Unfortunately, I don't have great answers. But I think asking why and understanding from the patient's perspective is more important. Yeah.
And that's really one of the beauties of this medicine is we're taking a look at the whole person. It isn't just, oh, you're drinking, you need to stop drinking. Well,
Right.
Why are you drinking? Why is that showing up? I think during the pandemic, we saw a lot of folks reached for alcohol out of boredom. They reached for alcohol as a coping mechanism. And so there are so many different reasons. There are some folks that have genetic predispositions toward isms, whether it's alcohol abuse or drugs or other maladaptive coping mechanisms. And so, I think that is the beauty of our degree is we get into the why. Why is this showing up for you? What is this a deeper meaning of? And helping folks to come to an understanding of why they're reaching for the drink or why they're reaching for, why they're over exercising, like you discussed, or whatever it is. So, I think that really is the toolkit piece for naturopathic doctors that helps guide our interactions with our patients. So I am going to wrap up today. Dr. Gordon, thank you so much for taking time out of your busy work schedule and all of your volunteer work that you do for the profession to speak with us today. And if you can just put up the last slide, which has the ANMC contact information, if folks have any additional questions, if we can be of assistance to you on your journey, really, really happy to help anyone at any time. There was a question, Andy, the webinar is recorded as soon as it's kind of uploaded and all of that. We will get that emailed out to all of the attendees. So just hang tight and it will come. It's kind of the end of the workday today. And so we will get that out shortly, but thank you so very much for coming and we will get the recording out for everyone. So
thank you for having me.
Thank you so much, Dr. Gordon. Appreciate it. And have a lovely rest of your evening or wherever you are. Take care.